Hello, everybody. I'm Dr. Josh Elo. I'm a psychiatrist at Rush. I'm joined here with my friend and colleague Ani Decca, also a psychiatrist here at Rush. Hey, Ani, how are you?
I'm doing well. Josh, how are you doing?
I'm good. I'm good. It's good to see you.
Good to see you too.
Uh, we've done a couple of these videos, and I'm very proud of us for waiting a whole three, I think, until we started talking about psychedelics. So I'm excited to start this conversation. A new paper that we're going to dive into today, looking at MDMA for PTSD when coupled with therapy. So this is a confirmatory phase 3 trial. Really excited to jump into this. Before we do, as I mentioned, I'm Dr. Josh Elo. This is Ani Decca. I'm a psychiatrist at Rush, do a little bit of research there, and then Ani is a CL psychiatrist, director of transplant. We're really excited to talk a little bit about PTSD because it's a problem. About 5% of the US population is affected by PTSD. And our treatments, we've got two that are FDA approved, sertraline and paroxetine. They help some folks, but a lot of folks are left with symptoms and maybe not getting enough treatment. 35 to 45, 47% don't respond. We do have psychotherapies. A couple are really great evidence-based ones like cognitive processing therapy, prolonged exposure. These are really effective, but the clinical trials that have been done with those have showed a really high dropout rate, maybe difficult for people to adhere to these. And so we need more effective and easier for people to access treatments. And that kind of sets the stage a little bit for what we're talking about today. So PTSD. PTSD is a really interesting disorder in psychiatry because unlike many of our other disorders, we know what causes it, right? Like there's a criteria A in terms of DSM, there's a criteria A incident, something bad and traumatic happens. At some point after that, you start having these symptoms. Neurobiologically, when we look at brain scans, looking at different areas in the brain where blood flows, we see that the amygdala, which is a threat detector deep in the deep part of our brain, the kind of reptilian part, that part gets really hyperactive, which makes sense when you think about a traumatic experience and then fear of something like that happening again. The amygdala gets a lot of blood flow. It tends to be pretty hyperactive. And then the brake, the part of the brain that's good at telling the amygdala to relax, everything's okay, recognize the context of what's going on. It's the prefrontal cortex. It's right behind our forehead up here. That seems to have less blood flow that's able to tell the amygdala to calm down. And this is the kind of basic connection that gets messed up in PTSD. So then you just have anxiety and you can't really be able to kind of think or talk your way out of it really without some extra help, without getting the prefrontal cortex working. So then if the amygdala is really ramped up, it's able to send signals to our fight or flight response, the HPA axis. And then that leads to, the anxiety living in our body, panic attacks, lots of avoidance behaviors, this physiologic arousal, loud noises make you jump, having a hard time sleeping, kind of relaxing. So then it shows up in your body. And then an interesting extra piece here. When we think about PTSD, we think about fear conditioning. Something bad happens and we get fearful, and then those triggers continue to give that fear response. And then memory consolidation, remembering that traumatic event and having this kind of downstream of effects. But something that was a little bit surprising to me, Ani, was when I was looking at some of the studies for the neurobiology of PTSD, it showed that there in the connectivity, resting state, functional connectivity of different areas of the brain being able to talk to one another, that the amygdala and the hippocampus weren't as connected as I thought they would. I thought fear and memories, they're going to be so close, but actually in PTSD, it seems like they're not as well integrated relative to healthy controls. I found that kind of interesting.
Yeah, so it seems like you mentioned, the amygdala is associated with the response to any scary emotion or thought, whereas the hippocampus is associated with learning and memory. It may be that what we're seeing, the studies are showing that there is this disconnectivity. The connection is not as strong in patients with PTSD between the hippocampus and the amygdala. And mind you, those are from a geographical location in the brain, they're very near each other. So the thought is that the hippocampus, if it was talking with the amygdala and had good connectivity with the amygdala, it could provide some context to the emotions that you're feeling because of the memory that is stored in the hippocampus, right? You can provide that context and help damp down that sudden rush of emotion that folks may feel when the amygdala is firing really hard. So it seems like in PTSD, that connection is more tenuous, so that context is not there and the amygdala is able to just take over without the consolidated memory which is stored in the hippocampus.
So, Ani, I think you and I both maybe think this way. When I approach a paper, I like to think about like that disease state, what we know kind of from a neurobiologic perspective, especially if it's kind of a new drug coming out or something kind of interesting and novel, so that when I go to look at why they're thinking about the study, if I can see if they kind of connect here. And so, as you listen to us talk about this, if you can try to keep some of these neurobiologic tidbits in your mind as we go through this, I think they'll help us as we circle back and maybe think about this paper kind of from a higher view after our discussion. So, Ani, tell me a little bit about the history of MDMA.
Yeah, very fascinating history of MDMA. Obviously, it's in the usual parlance, it's called ecstasy, right? That's how it's been more commonly known as. But interestingly enough, it was developed first by a pharmaceutical company. This was not like psilocybin. This was actually synthesized in the laboratory, and it was developed by Merck, which is one of the largest pharmaceutical companies, and they were trying to develop a sort of like a hemostatic agent for surgeries or bleeding. They didn't really get good evidence for that. In any case, and that was back in 1912. In any case, later on, this guy that you're seeing in this picture, I think he's got a toilet roll in his hands there, with all the paraphernalia of a chemist. So Alexander Shulgin. So he's the guy who resynthesized MDMA in the 1960s, in 1965, and he spread its use, and it was mainly being used at that time in psychotherapy, especially in couples counseling. That was where it was being used. And the name for it, right now it's ecstasy, right? At that time, the name for it was empathy. That was the name of the drug that the psychotherapists were using. But in any case, it was being used. But in the 70s, what happened was the war on drugs began, and MDMA was relegated to Schedule 1, which essentially means that there is no medical indication for the drug. So it's the hardest drug to really do research on or to study. In 2000s, thankfully, there was some movement towards restarting research on psychedelics, especially MDMA. And in 2017, on the basis of some of these phase 1 and phase 2 trials, the FDA gave the designation of what's called a breakthrough therapy, which essentially helps drugs to be pushed through the regulatory pipeline in a faster manner. And in 2021, we had our first phase 3 trial, again, in PTSD. It was by the same group. Now in 2023, that was in 2021, and now in 2023, we have the second phase 3 trial. In the interim, Australia became the first country to reschedule this drug to the point where physicians, psychiatrists, with some regulatory oversight, can start prescribing MDMA and psilocybin, for the matter of fact, MDMA for PTSD and psilocybin for depression. So, this new trial, the new study came out, the second phase 3 trial. So that's what we'll be discussing today. But this is sort of the timeline and the history of MDMA, how it was synthesized, and how it went through the regulatory pipeline.
All right. So knowing what we know kind of about the neurobiology, I think let's dive in a little bit about how MDMA works, a little bit of psychopharm. In psychiatry, specifically in depression, also in PTSD and bipolar disorder, we've essentially been working with the same monoamines for the past like 70 years. And those are serotonin, norepinephrine, and dopamine. And MDMA blocks the reuptake, much like an SSRI or SNRI or some of these other medicines, in putting more of those neurotransmitters in the synapse, in the space between the two neurons. So it's similar to some of the stuff that we already have, right? But then what's kind of cool is as we fast forward out of the monoamine theory of depression or PTSD, and we start thinking about neurotrophic, like growing brain, like brain health might be another kind of nicer way to say that. We see that MDMA also stimulates acetylcholine, which helps with glutamate release. It stimulates glutamate release, which is an excitatory neurotransmitter, and it stimulates brain-derived neurotrophic factor, which we're learning more and more with the neuroscience that all of our antidepressants at some point ultimately affect BDNF.
Reminds me of our last video. If you haven't checked it out, you should check it out. We had a very good discussion about BDNF and its downstream effects.
Yes, yeah, absolutely. So from a neurotrophic perspective, that's exciting and new and lining up with the neuroscience of what we want. And then a couple other things that are interesting here. The cortisol release. Cortisol is an important hormone that is released from our adrenals and helps us with kind of arousal. It does a few other things too. But the one that's really interesting about MDMA that I think is really worth highlighting as we look at people who are in this trial is oxytocin. Oxytocin has this pro-social kind of bonding, warm fuzzy feeling kind of neurotransmitter. And so this medicine, MDMA, stimulates oxytocin release. Put it all together here is a really interesting panel of effects.
The oxytocin, sort of like in colloquial terms, it's the love hormone, right? It sort of helps with bonding with moms and children, as well as between people who are in relationships. From a neurobiological standpoint and a neuroimaging standpoint, what we are seeing with MDMA is, number one, what we talked about, if you remember, we talked about the amygdala and the hippocampus and how they don't really talk to each other in patients with PTSD. It seems like after you take a dose of MDMA, there have been some neuroimaging studies which have shown that improved connectivity, improved connection between the amygdala and the hippocampus. So essentially saying that there is a more talk between those two, with the hippocampus helping provide that context that is so essential to these memories, difficult memories that patients with PTSD have to struggle with. The other thing is, with some of these imaging studies have shown that the blood flow to the amygdala is reduced when you are using MDMA, and that might help dampen down how reactive your amygdala is. So those are some of the neuroimaging correlates. They don't really give us a good answer as far as this is the mechanism by which the MDMA works, but at least shows us that there is some activity, changes in the activity of the brain that is happening. And from some preclinical studies, we can make some educated inferences that this might be the mechanism. From an anatomical standpoint and a neurobiological standpoint, it sort of makes sense.
Yeah, really good point. One other thing that I saw when I was kind of reviewing some of the neurobiology of PTSD is, that fear conditioning. You get into a situation and there's something threatening there, and the response is just so strong and so negative. In the MDA studies, not this one, but some of the prior to the phase 3s that we're talking about now, when they were looking at what's going on here, they theorized that when somebody who has PTSD has MDMA, there's something. The subjective experience is different, right? And you feel a little bit off, if I could say that, relative to how you normally are, right? Like you feel really, really good, and there's some like really positive emotions experienced there. And so theory is, okay, well, if we can take that kind of positive time, have it paired with some psychotherapy, what happens? And that lines up with this fear extinction idea. You have this experience, you're supported by somebody who you've already built a relationship with these preparatory sessions, and then that's a little bit different than what you expect. And then you have this expectancy difference where, normally when I get triggered about something and talk about my trauma or something, I have a really negative time. But in this situation, when I'm supported, it's actually not as bad as it normally is. And this change in the expectation is it's been described as a labile moment, a time when it's like, oh, what are we going to do with this? How are we going to put this all together? And the theory here is, well, by also supporting that time with serotonin and maybe a little bit of dopamine, a little bit of pleasure, a little bit of like positive emotion, that maybe we are able to put some positive pieces in that expectation change. It's just such a fascinating idea of how the panel, as I was mentioning, of this medicine actually from multiple different areas helps support that therapy and that change in the re-experiencing of the trauma that you get with therapy.
With the MDMA, I think when they were initially using it, what they found was, and this was in the 1960s, what they found was people subjectively experienced a more connected feeling. It was called an empathogen as well as entactogen. So empathogen is as in you are feeling empathy about for everyone else around you, and entactogen is that feeling of oneness within yourself. So you're more at ease with the internal thoughts and internal feelings that you have. And there are a couple with these two things, the empathogen and entactogen, there are two very important things. Patients with PTSD, often we see two things, right? One is difficulty with alliance with psychotherapists, psychiatrists, mental health professionals, right? Because the trust is not there. It's just the nature of the illness that folks suffer from in PTSD. And the second thing is revisiting those memories. The internal memories and the feelings can be very, very difficult. That's where the amygdala, that portion of the brain that we talked about, starts firing and makes it essentially impossible to revisit those difficult old memories, and you're not able to process it. The thought is what MDMA does is, number one, helps with this empathy. So you're able to connect. Empathy is a little bit different from sympathy. It's not sympathy. It's empathy is, can you put yourself in the other person's shoes, and can you have a good alliance with the other person that you're kind of talking with? So that alliance building is better. And secondly is the entactogen part of it, right? So you're able to revisit those memories without your amygdala firing to the point where those memories become very, very difficult to process, because you have to revisit those memories to really process them and digest them. But PTSD prevents people from doing that. You have those memories, but you're not able to process them, and they keep coming back, and you go through these symptoms, which are extremely painful. So that's the hope for MDMA. We're really excited to see what this new trial, this randomized control trial, shows us.
Well, maybe without any further ado, shall we? So this study was published just this month, is being published just this month in Nature Medicine. So it's a large randomized control trial of MDMA in PTSD. At the very top, we talked about this being a confirmatory phase 3. So there already was a phase 1, or a phase 3 called MAP1 that was positive. And so this, for those of you who don't know, when you go to the FDA, you need 2 positive phase 3s. So this is the confirmatory one, hopefully helping people feel confident that this is something that maybe could go forward to the FDA. So it's multi-site, 18-week trial. The outcome measures, the primary outcome was CAPS-5, the clinician-administered PTSD scale, which is the gold standard for PTSD. The key secondary was the Sheehan Disability Scale. So not just symptoms getting better, but like, are you getting back into your life? So this trial was supported by the Multidisciplinary Association for Psychedelic Studies. Interestingly, I think it's worth saying, in my opinion, they're kind of the gold standard for a lot of what's happening in psychedelics. So really glad to see them involved here. And then this study, we'll get into the timeline a little bit more. 3 dosing visits. This is not a one and done thing. This is 3 times that you're coming in to get MDMA or a placebo, and then the psychotherapy was throughout, which we'll touch on. So the folks were brought in, and before randomization, kind of pre-baseline period, you were seeing if they're eligible based on inclusion-exclusion criteria, and then folks who, if they were on any antidepressants or any kind of psychotropics, you were tapered off. So folks are not on any SSRIs or any other medicines psychiatrically when they come in. They're tapered off before randomization, I should say. So then there were 3 therapy sessions. There was a 2-person therapy team, so two people with the participant, and then folks got randomized. And then they received their first dosing, again, MDMA or placebo. And then they had an 8-hour session where they would hang out during that treatment. Then they would have some integration sessions, 3 of them, 90 minutes, and then another dosing about a month later, and then integration, and then another dosing. So 3 doses altogether. And then about 6 to 8 weeks after that 3rd dose is when we got to our primary endpoint. So, it's not like 1 and then we get a primary endpoint right after. It's not like 2. It took a while, and it wasn't right after number 3. Like, there was a bit of time there to see does this endure? Is this going to stay? Is it just like immediately after the dosing, there's something there and then it wanes? Like, those are important parts of how this one was designed. The dosing is interesting. The first one, they kind of did an introductory dose where they did 80 milligrams, and then they gave an extra 40 after an hour and a half or 2 if the clinician felt like it was warranted. And then 2 and 3, they did 120 with an extra, I think that's 60 actually. I think that's a typo. 60 milligrams dosed about an hour and a half to 2 after. So kind of ramped them up a little bit, but then those second 2 were at a higher dose. I don't think that we report on this, but like the vast majority ended up getting those extra doses in pretty much every one of the sessions. How come? CAPS-5, we mentioned that at 18 weeks, Sheehan disability at 18 weeks, And then there were some exploratory outcomes in terms of remission, loss of diagnosis, responders, and then obviously safety in terms of any kind of adverse events, and then suicidal ideation, vital signs. Those were what were monitored throughout the study. So when we're talking about methods, before we jump into the results, I think it's really important to talk about masking. This is a big deal in psychedelic research, right? Like it's been something that we've worried about with like ketamine studies. How do you, if somebody gets randomized to placebo, how do you not kind of unmask? An important part of our clinical trials are that they're double blind, right? The subject doesn't know if they're getting the active drug or not. We, as the clinicians who are maybe doing like MADRSs or Hamiltons or CAPS-5s or whatever it is that we're doing, don't know, to try to decrease that bias, right? And that's good for a lot of studies that are relatively inert, or there's not this obvious like intense effect. But as newer agents have more kind of robust immediate effects like ketamine or psilocybin or any of these psychedelics or dissociative agents, masking is becoming something that we're trying to figure out how to address. So in this study, a couple things are important. One, they did some surveys of folks who are the participants after the fact, and people in placebo, 75% of them were certain that they received placebo. So pretty sure like, hey, I don't think I got the active drug, but 20.5% inaccurately thought that they did get the active drug. So not everybody was right. That's an interesting piece when we're thinking about masking. For MDMA, 94% were certain that they got it, and very few thought that they didn't. So there was certainly like a subjective experience, I think we can assume from this. Now, the part that I think the folks who designed this trial did a really, frankly, good job with was using central raters. This has been a newer move, like clinical trials that we're doing here at Rush. We tend to use some mix of central raters, but for these studies, I think central raters are really important. They're not on site. They don't really know the patient, their demographics, or like really kind of anything about them. Typically, they're remote, maybe like a Zoom call or something like that, to try to add another level of like not getting unblinded by somebody getting dosed and they seem like they're having an experience, and so then I just saw them in the hallway and that's what's going on. So there's some real advantages here. And these folks took it to another level. They had the remote people. They had people who didn't know anything about the study design. And then they didn't know what study visit it was. Is this like a before I even get dosed, like a baseline? Is this like a third dose, which adds another level of decreasing that expectancy? I think they didn't obviously know what treatment the subject was getting, which is really important too. A couple other things that they worked on. They asked them not to read much about MDMA and PTSD, which I think is a really interesting extra level of trying to protect against this functional unblinding. And then nobody assessed a subject more than once. Oftentimes, we try to have the same person assess over and over again to try to decrease some maybe inter-rater variance. But this is an interesting approach to go the other way, to say, no, you're only going to do one based on, because all these folks did a lot of training for how to do the CAPS the right way. I recently did a study of PTSD where we did the CAPS, and there's a lot of extra training you have to do for it. So I trust that this is what happened. But they essentially said, like, you're just going to do this one, and then you're not going to see that person again, which is interesting because, you might make some comparisons. So going after this expectancy bias that might arise, I think they addressed it in lots of different ways, Ani.
Josh, do you know by any chance if they did like a inter-rater reliability?
I don't think they reported on that. Perhaps that was somewhere in the supplementary materials, but I didn't actually see that.
Okay.
Though I will say that what they did do in the methods, which was consistent with the study that we did, is that the CAPS assessments were recorded. And then those went to folks who essentially wrote the CAPS
Gotcha. Okay.
and reviewed them to make sure that they were asking them the right way and that they were scoring like, oh, you got a 4 here, I got a 3. Like, why do we have that difference? And like ensuring that kind of validity. And then they would continue to check several of them throughout the trial, not all of them, but that's a way that they tried to address that variability by reviewing actual recordings of how they did it in real time.
Yeah, no, I think they really put in a good effort to make sure that the blinding was intact. But I think we have to remember that with these psychedelic studies, this is not unusual. Even if these numbers might seem unusual to folks, these are not unusual in the psychedelic studies. The blinding integrity is very, very hard to maintain. And even the fact that 20% of the folks on placebo inaccurately thought that they were receiving MDMA is surprising in a good way, right, for this trial?
Yeah. So the results, the primary endpoint, This is the CAPS-5, right? This is the gold standard for PTSD, addresses all those different symptoms. You can see here in the blue, this is placebo with therapy. And just to pause for a second, the placebo isn't just like you get placebo and that's it. Like people were still getting psychotherapy in the same frequency as the people that got MDMA. It was just that the therapy was paired with the MDMA or the inert placebo. So you see that people in the blue, they got better, but the folks in the red separated. And Ani, I think, well, let me just say that after session 3, this is our primary endpoint at 18 weeks, we see a difference of about 9 points, which is substantial. Cohen's D of 0.7, which is pretty good with moderate effect size, maybe a little bit better than a moderate. But Ani, I think what's interesting here, before we jump to the Sheehan, after session 1, they didn't really fully separate. It wasn't until 2 and then it continued and maybe a little bit more at 3. I think that's really interesting because when we think about some of the other studies that we have, it's like a 1 dose and that's it kind of thing. This one didn't really separate after the 1 dose.
Yeah, that's really interesting, right? Because like a lot of the psilocybin trials, you kind of see this huge separation after the first session, right? And you're not seeing it here. But I think there is a paradoxical argument to this. We just talked about blinding, right? We talked about how it's easy to break the blind and know what group you're on. And that feeds into that expectancy bias. But the fact that there wasn't this huge gap between the placebo and the treatment arm, breaking the blind comes into play when you realize that you're not in the treatment arm. So what would be the normal thought process when you realize that you're not in the treatment arm? You'll immediately feel disappointed and you'll feel that your symptoms are not going to get better. But in this trial, it sounds like the separation immediately after the first trial, after getting the first medication administration, there wasn't a wide separation, which means that perhaps what we're seeing, to an extent, the response that we're seeing is the actual pharmacological response rather than breaking the blind and you're realizing that either A, you're on the treatment arm, so you are going to feel better, or B, you're not in the treatment arm and therefore it's a huge disappointment and therefore your symptoms are not any better at all.
Gosh, Ani, that's such a good point. I didn't really think about that, but that feels like it's a function of the way this is set up to support the psychotherapy, right? Like psychotherapy, although you and I are psychopharmacologists, like psychotherapy is good, it's effective, it works, right?
Yeah.
And I think that that's something that in a lot of our drug studies, we're really cognizant of not promoting a placebo response, like trying to be pretty neutral, trying not to be too empathic, trying not to be like over the top with participants who come in, just so we can try to minimize that to see if the drug actually does separate, to try to get at this biologic effect. But when you do it with a therapy, like I like to think like the therapists are working and doing what they're supposed to do, whether the patient's getting the MDMA or the placebo, right? And so you can see like, oh, this is what maybe standard of care, or if you want to call it that, and the placebo arm would be. But then, yeah, maybe this is more specific to the biologic effects when it starts to separate after that difference. So that's an interesting point and really kind of different about how we try to typically address the placebo in a lot of other clinical trials that aren't paired with therapy. So let's jump to the Sheehan. So secondary outcome, as Ani and I were discussing, like the disability, like functional impairment, does that change, not just symptoms? Similar in that after the first session, not a lot of separation, but then we start to see separation after session 2 and then the primary endpoint after 3. Not as big of a Cohen's D, but still significant, right? And so I think that's somewhat confirmatory in terms of it's not just artificial, it actually does change people's lives, which is, ideally what this the disability scale is able to help us understand.
And just to put like the Cohen's D into perspective, so that's like effect size. So we in a lot of these research studies, we use p-values for statistical significance, but for real world effectiveness or real world efficacy, we often use this other terminology, which is the Cohen's D or the effect size, which takes away a little bit of the sample size issues that come into play when you're looking at statistical significance, which means that larger the sample size, the likelihood of you getting a statistical significance would be higher. Like Josh mentioned, for the CAPS-5, the reduction in the symptoms of PTSD, the Cohen's D, which is the effect size, that means efficacy in the real world environment, was about 0.7. just to put that into perspective, for SSRIs, depending on which drug and for what indication, it ranges between like a zero point 0.3 to a zero point 0.5, right?
Yeah.
Like on a
Yeah.
good day, it's a zero point 0.5, but usually it's a zero point 0.3.
Okay.
So it's about like a double of that effect size that we're seeing here.
Yeah. Yeah. Yeah, that's a good point. And just while we're talking effect size, if we looked only at one arm, if we looked only at the placebo therapy, the effect size was 1.2, I
Yeah.
think. Like it was really impressive. I mean, so the therapy definitely works. But then this, I don't know how fair this is, but like the therapy plus the MDA, the effect size is like 1.9, I think is what I saw. I mean,
Mhm.
really, really impressive. So, but we're looking at the separation here, and I think that's what we can really hang our hat on is seeing how this is different.
Right. When we compare like oranges to oranges, it's like the treatment versus placebo, it's about 0.7. In the previous trial, it was like 0.9 for the effect size. It was a little bit higher in the previous trial, interestingly enough. And with the SSRIs, it's sort of varied between 0.3 and a zero point 0.5. So about 2 times higher effect size, at least in these trials that we're seeing.
Okay, what about remission? Improvement is good. Separation is good. It works, or so it seems. But then do people ultimately kind of get to what we really want clinically? Get them to be not impacted so severely by their symptoms, get into remission, get into like, not having this have a huge part of their lives. 71.2% of the folks who were in the active arm, they no longer met criteria for PTSD, as opposed to about half in the placebo arm.
Which is amazing.
It is really amazing, and then for remission. So how's this different? So PTSD diagnosis, right? Like there's 5 criteria, I believe, and each of the criteria have some number of different symptoms. And so in order to have a diagnosis of PTSD, you need symptoms from each of the different domains, and some of them you need a couple of them. And so maybe somebody didn't have the kind of re-experiencing phenomenon anymore, but did have like autonomic arousal and avoidance behaviors or something like that. So that would no longer be the diagnosis. That could still be a somewhat elevated score, severity, but remission then is essentially, instead of just 1 or 2 of these, it's kind of like taking all of them down. It's like a full kind of number better. So in the active arm here, we got 46.2% that went into remission. I think that was a CAP score under 10. Don't quote me on that. It was a low CAP score. And then the placebo is 21.4. So again, like still showing it's not just, the primary outcome. If we look and see if this is true, if this is real, if we can trust it with what some of these secondary outcome measures help us with, we still see that separation. And then a way to put that into clinical meaning, put it in the clinician's mind, is by using that difference and then turning that into a number needed to treat. Ani, do you want to explain NNT?
Yeah, it essentially means the number of people that you'll need to treat, people with PTSD or the diagnosis that you're treating, to get a positive response as far as loss of diagnosis in this case or remission is concerned. And just in normal terms, it's like if you had 4 patients and you treated them with MDMA, you would have 1 patient who would either lose the diagnosis or completely remit as far as symptoms are concerned. So it's actually a pretty good number when you compare it with other medications. I'm not sure what the other numbers are, but memory kind of serves me maybe like 7 or 9.
I
Seems
think
like,
Yeah, sorry. I think that the argument is anything like below 8 to 10 is like you
yeah,
got to start doing this.
yeah.
But some things have gotten FDA approved. I'm thinking of augmentation agents and MDD that
Mhm.
were less than 20, but not better than 10. And so this is impressive. This is a really good number.
Yeah, like 1 in 4, right? Which
Yeah,
is really good.
exactly. Ani, this was a bit of like pull apart. Like who are these people that get better? And tell me about this.
Yeah, I think that's the interesting part of these trials, right? You have these like big trials. This is not a very big trial. It's like about 104 patients, but still, it's hard to determine who are the people who benefits the most from this kind of treatment, right? You want to like parse it apart, and because that gives you guidance when you see your patient in clinical practice, when you see your patient and you see certain symptoms, then you can think about, oh, you know what, this patient might benefit really well from this medication versus the other medication. So they did this, what's called a covariate analysis, right? So covariates are essentially these characteristics of these participants in this trial, which they try to look if they affect the results or the response that the patients are getting from this trial. So if you look at this, I highlighted 3 of them. So the most important one is actually the SSRI history. Patients who've been on SSRIs previous to the trial, which is the usual pharmacological treatment for PTSD. Interestingly, what they found was that if the patient had a lifetime history of being on an SSRI, then it was associated with better efficacy of the MDMA treatment, MDMA assisted psychotherapy treatment, compared to if you were not on an SSRI. This is kind of interesting because there's been previous studies. So they had like phase 2 trials, right? They had about 6 phase 2 trials and they did a pool analysis of 4 of them. And they came up with this data, which tried to say that if the patients had previous SSRI exposure, then their response to the MDMA treatment would not be as good as if you were not taking your SSRI for a very long time or you were never on SSRIs at all, which is an important point because a lot of in clinical real life practice, when this treatment, if this treatment gets approved and if this treatment comes into play, I think it'll be an important point for clinicians to determine whether or not folks who have already suffered from PTSD for many, many years and have been tried on SSRIs and everything else, would they respond to the MDMA, or does that make them a poor candidate for this treatment? And this also kind of, it's a tangent into other facts, which we'll talk about a little bit later. What do you do with that treatment? If somebody is getting an SSRI already and, you know, they have some benefit from it, but not perfect, what do you do with it? Do you take it away and then just do it anew like they did it in the trials, which is easier to do in trials? But in real life, that comes with many other factors that you have to keep in mind as clinicians, as well as patients, you know, families, etc. So those are things which are difficult to figure out. But right now, what this data is telling us is that if you had a history of using an SSRI and maybe you benefited from an SSRI, that doesn't necessarily mean that you're going to do poorly. In fact, if you had a history of using an SSRI and had some response to an SSRI, you're probably going to do well on the MDMA compared to if you were not on an SSRI. The other two things which I just want to highlight are the sex assigned at birth and the BDI-2 score, which is Beck's depression inventory, which is a scale of severity of depression. What it showed was regardless of which treatment arm, whether you received placebo or whether you received the active medication, they tended to do better in terms of resolution of symptoms. If you were a female or if you had a more severe depression, then you tended to do better. What does it tell us? That kind of tells us a little bit about the common factor in the two arms. And what was the common factor? It was the psychotherapy.
Yeah.
Right. And like we saw in those graphs, even in the which is like the placebo, we call it the placebo arm, but it's really placebo plus psychotherapy, right? It's still an active treatment. They tended to respond fairly well to that, not as good as if you received MDMA, but you still tended to respond well to that intervention. And one interesting thing about this trial was that they used this new novel psychotherapy called inner-directed psychotherapy, which is a little bit different from the usual evidence-based psychotherapy that has been studied in PTSD, which is the cognitive processing therapy, cognitive behavioral therapy, other types of trauma-focused therapies. It's interesting, and it's something that we need to learn a little bit more about to see how this specific manualized inner-directed psychotherapy, how does that compare just by itself to the other forms of treatment that we have so far in PTSD?
Right. Because when you compare it to other ones we have, right? Because like we said at the top, like our current treatments aren't great. And so looking at who is going to respond is important. Typically, folks who have depression, like severe depression, major depressive disorder with their PTSD are excluded from trials. This one actually included folks. And I think maybe the table one is still to come, or maybe we skipped it. I'm not sure. But this showed that people who were depressed still responded to this therapy, but also responded to the MDA assisted therapy. One other point here, Ani, that I want to highlight, because you looked a little bit more at the first RCT than I did. This audit score. So AUDA is a score looking essentially at alcohol use disorder. Here in the right column, which essentially did the MDMA do better than the placebo, it didn't get all the way to a statistically significant number, which would be below 0.05. It got to a 0.1, which is interesting and important, I think, clinically, because alcohol use disorder, substance use disorder in general, are so common in PTSD. And this actually showed that the MDMA group responded well if there was some co-occurring alcohol use.
Yeah, absolutely. And I think with the previous trial, they've had a better signal as far as the audit score was concerned.
Right.
There was a more substantial difference in reduction of the audit score in patients who are receiving MDMA compared to placebo. And like you mentioned, alcohol use disorder is very significantly comorbid with PTSD.
Yeah. Yeah. Typically, these contribute to poor response, right?
Yes, absolutely.
Okay, here's the safety, but I do want to make a point actually in an awkward way of going back to table one, which, oh, here it is. Okay, we totally skipped over this. And I'm sorry,
Yeah.
I'm driving the ship and I goofed it up.
I was
This is
looking for that too.
I know. I don't want to miss this. And let's be honest. When I review a paper, it's really hard not to jump straight to the results. So, maybe this is real life. But let's go back and look at who these folks are who were even in this trial. So just to orient you, this is table one. Table one is in pretty much every RCT, which is just like, who are these folks? Demographic factors that might be interesting for the reader to think about who was in this trial and like, are these people like my people that I see in the clinic? And so a few ones that I wanted to highlight here. We talked at the front about how this study was pretty diverse. And when you look at RCTs, like they sadly tend to not be diverse. They tend to be predominantly participants who are white. This study showed some really interesting diversity in terms of ethnicity as well as race, which is really wonderful. I'm really happy to see something like that come of a big, important phase 3 study. Some other things I think are important, the duration of the PTSD. So if you look, I'm not sure if you can see my cursor, but if you come down here, 16 years, and these are matched, right? 16 years, folks had this diagnosis from probably their index trauma or the symptoms after the index trauma. That's a long time. You could consider that being relatively chronic. And I think that's important because if you think about like an acute traumatic episode and then the flooding of PTSD maybe for the next maybe 6 months or something short term afterward, that's a certain animal. But when you live with that for such a long time, kind of takes on a life of its own. And I think that could be to be fair, I don't know the studies for it, but that could be a place where resistance to treatment could show up when your life kind of, with anxiety disorders, this happens a lot. But like if your life starts shaping around coping with those symptoms. And so the fact that, the studies that we've been looking, or the results that we've been looking at were so positive, even with a relatively chronic course of PTSD, I think is really interesting.
The other marker for treatment resistance has often been the dissociative subtype of PTSD, where folks have dissociative symptoms, feeling of out-of-body experiences, things like that. And it's been shown to be hard to treat than folks who don't have that particular symptom within the PTSD symptom cluster. And in this trial, both in the treatment as well as the placebo arm, there was a substantial fraction of folks who had these dissociative symptoms. About 20% to 24% had these dissociative symptoms, which is again a marker of treatment resistance.
Yeah, also treatment resistance, comorbid depression. We were just talking about that because I think it's such an important point. When you look at this, 92.5% of the folks in the MDMA had a comorbid MDD diagnosis, and 100% of the folks in placebo. So having them involved is really beautiful. I'm really happy with that. The history of suicidal ideation, getting back to our last talk about how do we treat suicidality, these folks were not excluded. If you had a history, you were still allowed to be in the study, and you can see how prevalent SI was in this population. Looking at trauma history, we tend to think a lot about PTSD in that combat exposure vet population, because that's where a lot of the studies have been. Thank you to the VA. But this was a minority of folks in this study, which is interesting because especially you and I, Ani, when we're working at Rush, we're working on the west side of Chicago, like we see so many folks who have so many other types of trauma.
Yeah.
Not that it's just here in this part of the Chicago, but like we see a lot of different stuff. And so to see a study like this that is representative of a population that we see a lot of is exciting to think about how we could integrate this. All right, so then some therapy. And one other thing that I really wanted to highlight here was the ACEs score, the very bottom down here. So for those of you who don't know, Adverse Childhood Events scale, I think it's events, is a marker for essentially like awful things that happened in childhood. So this could be in terms of like big T trauma, or this could be like neglect. This could be things about having a hard time with safety at home and growing up. These folks had some difficult childhoods. You can extrapolate from this. And I think that's a really interesting point because, again, it's another symptom that we tend to think of, another demographic that we tend to think of breeding resistance to treatments. So the fact that they were in here and we continue to see these results, I think is important. Let me skip back or forward rather again to where we were. Safety. So we did see some transient changes in the vital signs, blood pressure, heart rate in the MDMA group. This is kind of expected given what we know in terms of its sympathomimetic structure and its effects, but nothing clinically, no clinical interventions were required. Nobody like needed to get put on antihypertensives or go to the emergency room or that sort of thing, which is good. And they seem to be transient, seem to improve after the treatment. There were some severe events that occurred in 3 of the MDMA folks and 2 of the placebo participants, but not a big difference between the 2, which is interesting. Another part here, typical side effects that we would probably expect from MDMA: muscle tightness, nausea, sweating, decreased appetite, and then bruxism. There are a few other, vision blurred. I mean, these are all sympathomimetic things. And then one other thing I want to highlight is about suicidality. Obviously, like we were just talking about in that table 1, this is a population that has a history of suicidality, and it could potentially come up as you're trying to get some treatment for the trauma that you've experienced. 2 folks in each arm had what seemed to be an immersion of suicidality. 1 in each arm engaged in some self-injurious behavior. But kind of interesting that relatively equal. Like obviously we don't want anybody to experience that, but there was no disproportionate incidence of that scary outcome in this study.
I think the caveat to that, and I think we should mention that, is the fact that both treatment arms had the psychotherapy component added to it. Because if you look back to our previous video, we sort of talked about the whole thing about emergent suicidality and how it's not a settled issue with the serotonergic medications, and also how with ketamine, biologically it's just not connected to the serotonergic medications, and therefore to put that label is a bit of a stretch. However, if you go by mechanistic properties in MDMA, it's a potently serotonergic medication. So I think the fact that they monitored for it was important, but also we have to keep in mind that both arms had the psychotherapy component added to it. And I wonder if we had an arm without any psychotherapy, what would that show? Would that show an increase in suicidality? Not necessarily because of serotonin per se, but because you are using MDMA, you are getting access to these very difficult memories now. You're able to more easily access them without getting overwhelmed when you're taking the drug, but the assistance with metabolism of those memories and processing those memories is not present because you don't have that assisted psychotherapy. What happens when the drug wears off and you're still left with those memories? If you are not yourself able to process them, not able to digest them, what do you do with those memories now, which you have easier access with, which came to the forefront very easily when you were using the medication? So those are questions which are unanswered here. That sort of makes me feel that at this point, with the evidence and the science that we have, if there is going to be an approval for this, which is again an if there is going to be an approval, it is going to be with an assisted psychotherapy protocol or indication.
Yeah, big question in the field about how necessary is that. But I think the safety monitoring piece of this, if that's what we want to call it, that the therapy provides, or the context for it, or the safety to go there and to think about those things, I think that's a really good point, and something I think we need to be really mindful of as we develop these treatments. Yeah. To summarize a little bit about because we've been talking about a lot of different parts here, there was a significant improvement in the PTSD score with the active treatment relative to the placebo. The diversity of this patient population, I think, is just a really interesting point for all of us who are clinicians, work in diverse settings, to be able to see that this is perhaps a bit representative of the folks that we see is exciting, and I hope a bit of a move in trials going forward to make sure that we prioritize recruiting a diverse pool of participants. Getting back to what we were talking about with the neurobiology and pairing some of those things that are dysfunctional in PTSD with what the treatment is here, it's really, really interesting to see how we've been able to target this monoaminergic system with the serotonin, norepinephrine, and dopamine. And then also, as we were talking about, try to get into that fear extinction, memory consolidation with the therapy support that the medicine assists with, and the pro-social stuff where we talked about the oxytocin, and I didn't put in here about the neurotrophic effects, but the really fascinating marriage of these treatments based on what we know from diagnosis. And then masking, we spent some time talking about how the central raters are a really interesting approach here that might help with being assured of what we're seeing here, and the effects are not because of knowing if somebody's actually on that drug, because you're, like I was mentioning, kind of in the hallway or around and being able to see that. Ani, I did want to highlight here something that we haven't really talked about, which is the dropout rate. This study was 18 weeks, right? Which isn't terribly short, but the dropout rate for folks who are on MDMA was 1.9%. I mean, that's really, really low.
Really low.
It's really low. Of the people who are on placebo was higher. It's 15.7, which is interesting. And I think you were mentioning a little bit about how this could be an issue with a lot of these psychedelic studies when it's clear that you
Yeah.
are not getting that you're not getting the active drug. Like, oh, do I want to stick around for this? But still, these numbers are dramatically different than what we see in the clinical trials for therapy, for cognitive processing therapy and exposure therapy, where it's about half drop out at the end of those manualized therapies. So this difference is really interesting to me, both because I think it helps us know that people like stayed in the study, and like, where did they go? Why did they drop out? What was going on here? That how are we going to interpret these results? But also, this still was therapy. This still was like meeting with somebody and talking about tough stuff, and people in this trial tend to stick with it, which I think is a really interesting difference.
Yeah, and it makes me curious about, because when you look at the 15.7% for the placebo arm, which is essentially placebo plus this psychotherapy that they came up with, makes me curious about the psychotherapy, right? They called it inner-directed psychotherapy, and they made it a point to note in their article that it was different from the CPT and PE psychotherapy that is usually used. So it makes me curious about that and how that might be utilized in more varied settings, and how we can look into it and see if this can be used for example, if somebody cannot use MDMA, is this something that we can just use separately from MDMA?
Yeah. Ani, tell me about this.
Yeah, so we want to first say that this trial was obviously a second phase 3 trial with a positive result. Pretty impressive result, to be fair. No major side effects that were noted. But there are certain things that we still have to keep in mind, even though I think they're inching very close to an FDA approval at this point. They already got approved in Australia, and I feel like it's a race between them and MDMA and psilocybin at this point as far as the psychedelics is concerned. But the concerns about durability remains, right? This was what, an 18-week trial. And like we mentioned, the average length of symptoms in this study was 16 years. 18 months in that frame is very short, and we don't really have answers as far as durability is concerned. And what do you do after a year and there's recurrence of symptoms? What is the protocol? Those are some of the challenging questions that we're still dealing with the other approved medication, newly approved medication, which is esketamine. We're still dealing with those questions about durability. Do we need maintenance treatments for this? How far along should maintenance treatments be? Things like that. So those are things that we still have to address. And I think these will be addressed in the real world setting once this is more readily, once it is more readily available. So that's like one big caveat that we should keep in mind. The second, I think we talked a little bit about the blinding, we won't rehash that. The other thing is recruitment, actually. With these psychedelic trials, there has been some concerns raised about recruitment because usually these are advertisements asking for participants for trials. People know that they're either going to get a placebo or a psychoactive substance or a psychedelic. And there have been trials where I'm not sure if they reported in this trial, but in the previous trial, they reported previous experience with MDMA, and about a quarter of the participants has had previous experience with MDMA. And that gets you wondering, could be in either way, it gets you wondering, how does that influence the results? So there's been some questions raised by recruitment, but that's how trials are done. All trials are done, and I don't think it should be different for this specific drug just because it's called a psychedelic. The other things, I think, again, 18 weeks, we saw that the side effects were fairly minimal. There were certain serious side effects, but for the vast majority, there weren't any. But beyond 18 weeks, if we need to start using this as a maintenance treatment, what are the long-term side effects? What do we get into here? Those are certain big questions that arise. And then again, if you look back to the side effects that were reported, which included body temperature regulation issues, irritability, issues with tremors, bruxism, if you look at it together, again, those were reported separately and it's not like a big number. But if you look at them together, a lot of these symptoms remind you of serotonin toxicity. And you have to keep in mind that this is a profoundly serotonergic drug. It works very predominantly on the serotonergic receptor. It's much more serotonergic than the SSRIs. So what is the risk of serotonin syndrome, especially if patients are on other serotonergic medications, whether SSRIs or other non-psychiatric medications, which have serotonergic properties? And again, that brings us to that question that we talked about. What do we do with folks who are already on SSRIs? What is the way to go? The easy answer might be just take them off the SSRI and start them on MDMA. But then in the real world, things might not be as simple because people get real benefits from SSRIs without causing complete remission of symptoms. And then what do you do with it? Do you run the risk of taking them off and starting the MDMA, or do you run the risk of a serotonin syndrome or a serotonin toxicity picture? So those are things which remain unanswered, and we'll have to keep looking for more data. The other things, more practical things, how do we get the manpower for the psychotherapy? How do we get the people who are trained appropriately for this specific type of psychotherapy, which is the therapy which is being shown to have better alliance, better retention rates, better outcomes? How do we train folks for this? How do we get folks to be paid to do this? And that's where the cost benefit analysis of a capitalistic society comes in. What is the equation that insurance companies are going to look at to determine whether or not this is worth their time and money? So those are things that I feel we'll have to tackle with as they come along. And then finally, the other thing that I was thinking about is like other uses. This is shown to be effective in these two phase 3 trials in management of PTSD symptoms. But interestingly, like you said, Josh, this trial was very comorbid with depression. And in the other phase 3 trial in 2017 that had come out, they actually did an analysis of the Beck's depression inventory rating scales. And there was statistically significant improvement in depressive symptoms in the BDI-2 scale in the treatment group compared to the placebo group. So does this translate to it being an efficacious drug for folks with depression? The other thing that comes to mind is what we talked about initially in the mechanism of action and what role does serotonin, MDMA, and oxytocin play a role, the pro-social aspect, right? Reduction in fear, but also that pro-social element that comes into play. One of the hardest diagnoses to treat and help patients is autism spectrum disorder, especially folks who have difficulty with social anxiety and socialization. Does this come into play there? We talked about it being an empathogen and entactogen. And with autism spectrum, we often feel that the ability to put yourself in another person's shoes is a little bit more difficult and challenging. Does this help in that aspect, reduce social anxiety, improve ability to connect with others, as well as the internal feelings of oneself? So I think really exciting, and people are already looking at it, but I think once this becomes more mainstream, people will be able to branch out into other indications and see if this may have a role beyond PTSD. And if not, if it is just for PTSD, I think it still makes sense because it is such a difficult disease to treat and so many people are struggling with it. And the statistics that we discussed, it's very hard to treat. Dropout rates are high. There's difficulty with alliance building. There's difficulty with medications. So if the results bear out, then I think this is a very promising treatment for PTSD.
I love thinking about other uses. It's such an interesting idea,
Yeah.
and I think you bring up some really excellent points. One other one that I want to add, like if we back up to the neurobiology again, like an overactive amygdala is so central to so many of our disorders. And so if this really does kind of attenuate that hyperactivity, like gosh, that could be really useful for a bunch of things. And when we think about the neurobiology of borderline personality disorder, it's a very similar look with this hyperactive amygdala and the decrease in the firing from the inhibitory medial prefrontal cortex. And so also kind of needing some maybe pro-social effects is a really interesting idea in that disorder. Obviously, there's tons of mood issues there. Like I like thinking about lots of different uses potentially, and I'm sure we could come up with a few more. But it's an exciting thing when we continue to target this underlying neurobiology with specific treatments. It seems to be really effective in this one PTSD, and who knows where we could potentially go from here. It's an
I
exciting time.
feel it's very exciting times for psychiatry. MDMA has, like we discussed the history, right? It's had this very storied history, how it started, where it went, and now it's sort of coming back. It reminds me of this Hegelian pendulum, right? Like you kind of
Mm.
go from a thesis to an antithesis. So that in this case, the thesis could be in the 60s or 70s. This is the panacea for everything. Let's use it for, psychotherapy, couples counseling, whatever you will. And then you have the antithesis, probably a little bit too far, that
Mm.
let's make it Schedule 1,
Yeah.
because this is, a substance of abuse or something like that. And now you have the synthesis. I think that we're in the right direction where people are doing good, rigorous trials, not just like one or two trials. There have been several trials because you have to take into account the phase 2 trials. There have been 6 of them.
Yeah.
And now we have 2 of these. And we are synthesizing data, we're being careful, and we are bringing it together. Obviously there's still a lot of unanswered questions, but that's the case for everything, right? Like for a
Yeah.
lot of the medications that we've already approved via the FDA, there are a lot of unanswered questions, and there's still like post-marketing surveillance, things like that are going on. But I think the stigma of being a Schedule 1 drug is on all of these medications. And it's very interesting to see how things have panned out, at least in the last couple of decades, for MDMA especially.
Yeah. Yeah. Very exciting. I agree. Ani, as always, great time. Thank you so much for the discussion. I really enjoyed talking about this with you. Thank you so much for watching. And on behalf of Ani and myself, I'm excited for the next time we get to have some time together.
Yeah.
Thank
Take
you.
care. Bye bye.